So good morning, everybody. Thank you, Dr. Ajay, Dr. Waleed. It's a pleasure to be back here. I have 30 minutes to start the first presentation, so we'll go ahead. So the first presentation is to really talk about scleroderma-associated lung fibrosis. Rajai, will we ask the question at the end of all the three talks? Yes. Okay, thank you. Here are my appropriate disclosures. So here are the three objectives that I want to cover by the end of the 30 minutes. Talk about a little bit about natural history of scleroderma ILD, discuss the management, and then talk a little bit about the nintedanib trials. It is FDA approved. I know it is available out here, and a lot of physicians are starting to use it and ask questions about it. So the first take-home message is that majority of our patients have interstitial lung disease. If you do a CAT scan of a patient in systemic sclerosis, 70% have associated lung fibrosis. However, only 25 to 30% develop progressive ILD. So as a rheumatologist, one of our goals is who is that patient who will develop progressive ILD so you could treat them early. Why is that important? It's largely irreversible, and the goal of the therapy is stabilization. The treatment includes immunosuppressive therapies. We'll talk about mycophenolate, Cytoxan, and the role of antifibrotic therapies. So this is a paper we just published in the Blue Journal, or the American Journal of Respiratory and Critical Care Medicine. And I think as more advances are being made in the diagnosis of systemic sclerosis, I think there are three things to keep in mind. There's an upfront endothelial and epithelial injury, maybe due to gastroesophageal reflux disease, maybe due to unknown autoimmune parameters, leading to profibrotic expression of different cytokines, myofibroblast transition, and failed resolution. This is where all the therapies that we are using not working anymore. There we go. Well, it goes away, it comes and goes away. So this is where most of the therapies are being used for the management of systemic sclerosis. The other thing for rheumatologists that is very important to understand is to differentiate different patterns on HRCT. The two most common patterns of ILD on HRCT are non-specific interstitial pneumonitis, which is associated with ground glass opacity, as you see out here, increased interstitial markings, which is majority of the patients with scleroderma or dermatomyositis. On the other hand, if you have a patient with rheumatoid arthritis, you will see this UIP pattern with honeycombing, which is about 10% of the patients with scleroderma, but majority of the patients with RA-associated ILD. Again, most of the things that happen in systemic sclerosis happen early in the disease. So this is where the interstitial lung disease, renal crisis, myocardial involvement, the first 5 to 7 years are very critical in the disease course of a patient with scleroderma. And this is the data by Professor Denton showing that autoantibodies play a very important role in diagnosing patients who have progressive interstitial lung disease. Here's the data on patients who had centromere antibody, and you see the proportion of patients who develop progressive ILD is about 5%. So if you have a centromere antibody, the likelihood of you developing bad ILD is very, very low. If you had anti-topoisomerase antibody, irrespective whether you had limited or diffuse scleroderma, the proportion of patients who develop progressive ILD is 75%. So you can do an antibody profile in a patient and determine the likelihood of them developing progressive ILD and manage, screen, treat appropriately. And this is a very old slide from Dr. Steen showing the majority of the decline. Once you have ILD, the majority of the decline in lung function happens in the first 5 to 6 years. And after that, the disease goes into a more burnt out fibrotic disease on average. And this is the data from Dr. Steen, and this is the data from Dr. Denton, again showing at 60 months out here, if you can see my fading green light, at 60 months out here, you start to see that most of the patients have had the damage that needed to be done for progressive ILD. Can you give me another one of these? Is there another one? So here are the predictors of progressive ILD: male, gender, early disease, African Americans. But I think if you have to take two at home for management, it's the anti-topo1 or SCO70 antibody, nucleolar pattern on ANA, and diffuse cutaneous systemic sclerosis. So those are the two factors in clinical practice that would be very, very helpful. Now, how many of you do HRCT on every patient with scleroderma for screening? So about 20 to 30% of you. Pulmonary function test lacks sensitivity to diagnose early ILD. In other words, if you have interstitial lung disease, in 1 in 4 patients, pulmonary function test is absolutely normal. At University of Michigan, we do HRCT with prone imaging. Here's a patient with increased interstitial markings that are persistent when the patient turns around into the prone imaging versus a patient who had dependent atelectasis. On the supine imaging, you see a little bit of interstitial markings out here. So you see interstitial markings out here that go away. That go away when the patient goes into the prone imaging, highlighting that this is not early interstitial lung disease, but dependent changes. So here is how we manage. We do HRCT in every patient. And if there is no ILD, I told you that early progressive ILD occurs in the first 3 to 5 years. We do lung function test every 4 to 6 months. By lung function test, I mean a forced vital capacity with diffusion capacity. If they do have ILD, we differentiate them into subclinical ILD, which is majority of the patients, i.e. very minimal ILD, normal lung functions, and no symptoms associated with ILD. And we further divide into a low-risk phenotype, which I'll talk about, or a high-risk phenotype, which is based on the recent clinical trials, diffuse scleroderma patient with topo1 or diffuse scleroderma patient with elevated CRP, and we have started to treat these patients, and we'll talk about the treatment. If the patient has clinical ILD, if the patients do have clinically meaningful ILD, which is majority of the patients, if you do not do HRCT, these patients should be treated. So in your mind, you can divide patients into subclinical ILD versus clinically meaningful ILD and come up with an algorithm to treat them early and aggressively. So the treatment of progressive ILD, don't forget about whether they have hypoxemia with the hall walk. Most importantly, tell every patient with scleroderma to sleep at an angle, do the pharmacologic and non-pharmacological management of interstitial lung disease and GERD. Now, here are the concepts in my mind when a patient with scleroderma comes to me, and how do I manage? The first question I ask is, do they have ILD on HRCT? If they do have ILD on HRCT, do you want to treat them? I told you a large proportion of patients have subclinical ILD. Not every patient with scleroderma ILD requires treatment. If you decide that these are appropriate patients who should be treated, then treat the underlying autoimmune disease, which is with immunomodulatory immunosuppressive therapy. At our practice, we use mycophenolate mofetil or Cellcept as the most common therapy for the management of this patient population. If they do develop progressive ILD, so you see that their lung function is declining despite being on immunosuppressive therapy, that's the time we change immunomodulatory therapy or add nintedanib and antifibrotic therapy. I think there are trials that are about to start and ongoing. What happens like in rheumatoid arthritis, like in different inflammatory arthritis, if you use upfront combination of both nintedanib, pirfenidone, and immunosuppressive therapy. So this slide highlights the treatment of progressive ILD. I told you majority of our patients are on mycophenolate. Is that the case out here? Most of you use mycophenolate? So majority of us use mycophenolate, remember, up to 3 grams per day in divided dose. Start at 500 milligram twice a day for 2 to 3 weeks, 1 gram twice a day for a month, and then 1.5 grams twice a day for a month. I would say 70% of our patients are able to tolerate. 30% who are not, we either decrease it or go to myphotic, which is mycophenolic acid sodium. If they have progressive ILD, despite that, we do add sometimes rituximab therapy. Very rarely now we use cyclophosphamide, and then there are other aspects that I briefly will talk about, including nintedanib. So I want to mention one trial that I did, and that is about to get published in Lancet Respiratory Medicine, where we took patients with early diffuse scleroderma who had elevated CRP. So they have elevated acute phase reactants, have early diffuse scleroderma. They were given tocilizumab, Actemra, or placebo. And what we saw in this trial at baseline, the patients had normal forced vital capacity, but 65% of the patients had ILD on HRCT. They were not chosen for ILD. These are patients who are coming to you, early diffuse scleroderma. 50% of them are anti-topo-1 positive. And these are the patients who did HRCT. And what we saw is that if you received tocilizumab, there was stabilization of lung function, whereas if you had a placebo, you had almost 238 ml or a 6.5% decrease at 1 year. A very large difference in stabilization or preservation of lung function on Actemra versus a clinically meaningful decline in lung function in placebo in very early ILD. So this is a patient population. If they come to me, early diffuse scleroderma, so I'll go back again, early diffuse scleroderma, even if they have normal forced vital capacity and minimal interstitial lung disease, these are the patients we treat with Actemra or other immunosuppressive therapies at University of Michigan. Again, I wanted to show you another slide from this trial, which is important. If you had anti-topo-1 positive or SCL70 positive in early diffuse scleroderma, this is a decline in the placebo group over a period of 1 year, almost an 8% decline on average. So the take-home message is if you see an early diffuse scleroderma patient with topo-1 positive and early ILD, treat them. Do not wait them to get here at 1 year and then start treating, because you have lost almost 8% of the lung function. That is irreversible. Scleroderma ILD treatment requires long-term treatment. Used to be when I started my training with Dan First and Phil Clements, they taught me to treat them for 3 years. Then it became 5 years. To be honest, now I treat them very, very long-term on mycophenolate. Some of my patients are 10, 15 years and they're still continuing on mycophenolate. I've seen about 25 to 30% of the patients flare. You take away their mycophenolate, they start to flare, they start to have a decline in their lung function. So my recommendation now is longer-term mycophenolate and other therapies unless they have contraindications associated with that. So we talked about this paradigm, the management of scleroderma ILD. This is a review that Rajai Namas is also involved, that is upcoming in a journal. So I want to talk a little bit about, focus the last few slides on nintedanib. Is nintedanib available here? How many have used nintedanib? Anybody has used 1, 2? So very few people have used nintedanib, and it's a paradigm change how rheumatologists and pulmonologists treat scleroderma-associated interstitial lung disease. Nintedanib is already FDA approved for idiopathic pulmonary fibrosis. So I showed you in my initial cartoon that the epithelial and endothelial injury leads to a cytokine storm that includes the pro-fibrotic cytokines and pro-inflammatory cytokines. And there are receptors, including tyrosine kinase receptors, that translocate the cell signaling into the nucleus, causing the fibrosis and myofibroblast transition. And nintedanib is a pan-tyrosine kinase inhibitor that targets different cytokines. So it blocks those cytokines to have a downstream effect leading to myofibroblast transition and fibroblast activation. So this is a trial that Oliver Distler led that was published last year in New England Journal of Medicine called Census trial. They took patients who had scleroderma-associated ILD. Half of them received nintedanib, 288 patients. Half of them received placebo for a year. So who were the patients? The patients had scleroderma within first 7 years. It's very important to know that because you do not want a patient with scleroderma who has a 20 years of ILD to be started on this drug. So scleroderma patients in the first 7 years with a lot of lung fibrosis, abnormal forced vital capacity and diffusion capacity. So if you look at my algorithm, majority, if not all, the patients had clinical ILD. They were symptomatic, they had abnormal forced vital capacity, they had a lot of ILD on HRCT. They were allowed mycophenolate for more than 6 months prior to randomization. So the patients majority were Caucasian. Half of them had diffuse scleroderma. Average age of onset was 3.5 years. 60% were topo 1 positive, and half the patients were taking mycophenolate. Okay? And the forced vital capacity predicted was about 72%, unlike tocilizumab, which was 82%, and the amount of fibrosis on HRCT was about 35%. So a lot of lung fibrosis, abnormal forced vital capacity, abnormal diffusion capacity. Think about the patient in your practice. We have a lot of patients who look like this. So this was the primary endpoint. This is nintedanib. The decline was about 52 ml, and decline in placebo was about 93 ml, with a total decline of 41 ml. Remember, all of us, after the age 25 to 30, lose 25 to 30 ml every year in forced vital capacity. That's why when you do your forced vital capacity, it is adjusted for your age, your gender, your ethnicity, and your height. That's why it's called forced vital capacity percent predicted. But if you take your FVC in ml, there's about a 25% decline in all of us every year. So the improvement that was seen here, or the reduction in decline, was very, very small, very modest. But you do see the decline in nintedanib versus the decline in the placebo group that started to differentiate at about 12 weeks, statistically significant. Now, when you look at the different aspects that were related, you look at this diagram out here, there was no differentiation whether you had diffuse scleroderma, limited scleroderma, your ethnicity. The only difference really was the patients who were treated in Canada and US, majority of the patients were on mycophenolate. The improvement was very, very, very small. I mean, the improvement was 10 ml, which is about 0.3% predicted. So the improvement or the difference was very, very small here. And indeed, if you look at patients who were on mycophenolate, the difference was only 26 ml, which is about 1%, compared to patients who were not on mycophenolate, the difference was about 55%. So the take-home message out here is that if you have a patient with scleroderma-associated ILD, they are on mycophenolate, they are not doing well or progressing, then you may consider adding nintedanib to their therapy. Do not remove mycophenolate, add nintedanib. One of the biggest issues of nintedanib was there was no improvement or change in the skin score. This is nintedanib or placebo, no improvement in symptoms and function. So the patient did not feel anything. The patient did not have an improvement in the skin, function, or feel, and indeed, there were a lot of dose reduction in nintedanib because of diarrhea, nausea, vomiting. So when you talk to the patients, you have to guide them that they will get a lot of side effects associated with this medication, so remember that. Here are the side effects: diarrhea in about 76% of the patients compared to 31% in placebo, nausea 31 compared to 13, vomiting 25 compared to 10, and weight loss in 12% compared to 4%. So it's very, very important to tell the patient, because patients like us don't take drug for improvement in lung function. They take medications to make them feel better. The drug does not do that. I will move to another trial by my colleague, Kevin Flaherty. This trial was again published in New England Journal, which is important for all rheumatologists, where they again treated patients with nintedanib or placebo. But they treated a patient population that is important to us, progressive fibrotic ILD. Patients who come to you, they are on mycophenolate or with rheumatoid arthritis on anti-TNF agents and others who are declining in front of you. So they have declined a 10% forced vital capacity over the last 6 to 12 months. They have a relative decline in lung function and worsening symptoms, a decline in lung function and increased fibrosis, worsening or respiratory symptoms and increased fibrosis. This is real life. The patients come to you, they are getting more short of breath, you do their lung function has declined. So real life clinical trial design. And majority of the patients had UIP. So when you think about rheumatoid arthritis, you think about Sjogren disease. Most of those patients have UIP pattern, which is again this honeycombing that I talked about. 2/3 of the patients had UIP out here. Age 65, majority were male here because it was a combination of different fibrotic ILDs, a forced vital capacity of 69% and a diffusion capacity of 44%. So just to highlight, there were different autoimmune and other diseases that were part of this ILD diagnosis. Here is our autoimmune ILDs, which was here. CTD ILDs, they had hypersensitivity pneumonitis, they had non-specific interstitial pneumonia, everything. But we will focus on our patient population, which is CTD ILDs. So when you look at the patients who had CTDs, ILDs, majority of the patients had rheumatoid arthritis and Sjogren-associated ILD. Nintedanib had a big impact on preventing progression of ILD compared to placebo, a delta difference of 102 ml, compared to the Census trial where the delta difference was 41 ml. So it's almost 2.5 to 3 times the delta difference that you saw with the Census trial. So if you have a patient now, the way I treat it, you have rheumatoid arthritis ILD, all of you treat that. Sjogren's ILD, myositis ILD, Dr. Chet Otis is here, he will talk about some of it. If they have progressive ILD despite on your immunosuppressive therapy, you can consider adding nintedanib, especially if they have a UIP pattern on their HRCT. So this is one of my last slides. If you have ILD on HRCT and the patient has subclinical ILD, very minimal ILD, normal lung function, anti-centromere antibody, as an example, the risk of progression there is very, very small. It is appropriate to closely follow this patient and see if they develop progressive ILD. So that patient population, limited scleroderma patient population, in my mind, with very minimal ILD, normal lung function, really not symptomatic, requires immunosuppressive therapy. However, the paradigm change in my mind is if you have a group of high-risk ILD, the patients have diffuse scleroderma with anti-SCL70, early diffuse scleroderma with elevated CRP. I showed you in the tocilizumab trial, these patients can lose 6 to 8% of their lung function at the end of 1 year. If you and I had this disease, we will not wait to develop clinical ILD. We want to treat these patients early. And in this patient population, this is not yet FDA approved. Tocilizumab weekly or mycophenolate is the treatment that we use at University of Michigan. On the other hand, if they have clinical ILD, but have no skin musculoskeletal involvement, remember I told you nintedanib does not work for skin, does not work on function, does not work on scleroderma as a whole. You can choose, if everything is quiet, you can try to use nintedanib or mycophenolate, but majority of the patients have active skin and musculoskeletal disease, and we tend to go with mycophenolate in this patient population. So the answer, you can take mycophenolate, 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 add nintedanib if they have progressive ILD. The only exception is if they are high-risk phenotype with subclinical ILD is tocilizumab. And if they have worsening or progressive disease, There are really no clinical trials. This is eminence-based medicine, rituximab, use cytoxin, use nintedanib, other therapies that you may have. So I want to end with two patients. I still have a little bit of time. So these are the two patients that we see now about 2,000 scleroderma patients at University of Michigan. So we have about 400 or 500 patients with scleroderma ILD that we see on regular basis. So I just took the last two patients I saw on Monday and just looked their pulmonary function test and took the pictures of those. The first very important part of pulmonary function test is that you need to have this over time period. So this patient has been seeing me since 2012, and this got cut here. So you can see that the lung function of this patient, a long-standing diffuse scleroderma, moderate ILD on HRCT with UIP, mycophenolate in divided doses. She comes every year. I do her echocardiogram, I do her pulmonary function test. She has no change in symptoms and her hall walk shows no desaturation. Her FVC is 40% for the last 8 years or so. Her diffusion capacity is about 50% for the last 8 years or so. Would you add nintedanib in this patient population? No. How many of say yes? So I agree. This patient has long-standing diffuse scleroderma, has no change in her symptoms, the things are stable. The key part in her is continue to vaccinate her, because if she develops a pneumonia or influenza, there's a high risk of progression and decline, number one. And number two, continue to educate her of GERD management and continue her mycophenolate. This is a patient population or a patient I will not stop CellCept, because if she declines any further, she'll either die or will require a lung transplant. Here's another patient, a gentleman, very early diffuse scleroderma, mild ILD on HRCT, CellCept 3 grams in divided doses. So his lung function is 90%, and his DLCO, you can't see very well, is about 100%. So as normal as it gets, he has mild ILD. I repeated the CAT scan because he had a big nodule. And the CAT scan showed worsening of the ILD. There were no change in the symptoms, but his forced vital capacity decreased from, DLCO is here. Forced vital capacity decreased from 90% to 78%, DLCO 60% to 40%. No change in symptoms, no change in desaturation. Would you treat this patient? So, that is the point. That is a take-home point, that even if somebody started normal and they reach 78 to 80%, they're still quote-unquote normal, but there's a clear clinically meaningful decline. In this patient, the choices include, he's on mycophenolate. You can change it to Actemra. In this case, we added nintedanib to CellCept in this patient population. So to end my presentation, scleroderma ILD is a leading cause of morbidity and mortality. FDA has provided an approvable pathway for management of ILD, which is forced vital capacity. Targeting the scleroderma ILD with immunomodulatory therapy. I've heard today that MMF is also the initial therapy of management of scleroderma ILD here in this country. And the role of antifibrotic therapies, progressive ILD on mycophenolate, predominant ILD with no skin or other manifestations. This is not uncommon. Recurrent infections on mycophenolate, recurrent UTI, recurrent bronchitis, that where you may be able to use nintedanib. And if you are fortunate to get both, patients who are very progressive in front of you, they have diffuse scleroderma, they're mummified, they have severe ILD, you may consider combining upfront mycophenolate and nintedanib. Thank you very much.